Okay, let's jump into a topic that comes up a lot for anyone expecting. Epidurals during childbirth.
Absolutely. It's something people often have strong feelings about or just lots of questions.
Right, and maybe you've got a super detailed birth plan, or maybe you're just starting to explore the options.
Exactly. So today we're diving into an article from Yale Medicine, and it features an obstetric anesthesiologist laying it all out.
Yeah, getting it straight from an expert. Our goal here is really to unpack the facts, the experience, the safety stuff based on their perspective.
And it's a common choice, for sure. The article mentions, 75% of women giving birth in the U.S. use one?
Wow, that many.
Yeah. And the expert calls it the most common and, importantly, the most effective pain relief method for labor.
So definitely worth understanding properly. Let's start with the basics then. What exactly is an epidural? How does it work?
Okay, the procedure involves putting a needle and a very thin, flexible tube, a catheter, into the lower back.
Into the epidural space, right?
Precisely. That space is just outside the membrane that covers your spinal cord. Once the little catheter is threaded in, the needle comes out.
Ah, so the needle doesn't stay in.
No. Just the soft catheter stays taped down, ready to deliver the medicine.
Gotcha. And the medicine itself, what are we talking about?
It's usually a mix. A local anesthetic, think something like Novocaine you get at the dentist, but formulated differently, of course, combined with an opioid.
Like fentanyl or hydromorphone?
Yes, those are common ones.
Okay, so hearing opioid might make some people pause. Why is it considered safe here, especially for the baby? And why doesn't it make the mom drowsy like other opioids might?
That's a really crucial point. It's all about where the medicine goes and the concentration. It's delivered in pretty low concentrations, and it mostly stays right there in that epidural space. So very little actually gets absorbed into the mother's bloodstream. That means only a tiny, tiny amount can cross the placenta to the baby.
Much less than if you took it by mouth or IV, presumably.
Exactly. That's why the mom generally stays awake and alert, not drowsy, and why it's considered very safe for the baby compared to, say, general anesthesia.
That localized effect is key then.
Yes.
So what does it actually feel like when it's working? What's the effect?
It creates this band of numbness, usually from about the belly button down to the top of the legs.
So targeted numbness.
Right. The goal isn't total paralysis. It's to block the sharp pain of contractions while still allowing you to feel pressure, know when to push, and stay fully awake and present for the birth.
Okay, that makes sense. Relief without being totally out of it. Let's walk through getting it. Does the actual placement hurt?
Yeah, people definitely worry about that. They numb the skin on your back first with a small injection. That little shot might sting a bit.
Like any injection.
Pretty much. But once that area is numb, when they insert the actual epidural needle and catheter, you should mainly feel pressure, maybe some pushing, but not sharp pain.
Okay, initial sting, then pressure. Good to clarify. And once it's all set up, how fast does the pain release start?
The whole placement procedure takes about maybe 10 minutes or so, and then you should start feeling significant relief kicking in around 15 minutes after that.
15 minutes.
Yeah.
Not too long to wait. And does it last? Or do you need top-ups?
That's the advantage of the catheter staying in. It's connected to a pump that delivers the medication continuously.
Oh, okay.
So, yes, the relief lasts for as long as your labor lasts, right through delivery.
Continuous relief sounds vital for getting through a long labor.
Yeah.
What about the timing? When can you actually get one? Do you have to wait until you're dilated a certain amount?
This is a big one. They basically say you can get it almost any time during labor.
Really? Anytime?
Pretty much. As long as you can sit or lie still for those few minutes it takes to put it in. The only real exception is if the baby's head is, like, right there, crowning. Then it's too late.
So that old idea of having to be, 4 or 5 centimeters dilated.
Yeah, that's outdated. Based on current ACOG guidelines they mention, if a woman requests pain relief, that's enough reason. They say they've put them in when someone's just 1 centimeter dilated.
Wow. Okay, so flexibility is key. That's really empowering.
It really is.
What about the concern that getting it, especially early on, might slow labor down?
There's some evidence it might slow things down slightly, maybe by about 20 or 30 minutes on average.
Is that considered significant?
They kind of frame it as a possibility, but maybe not a major factor for most.
Right. So the big message seems to be, you have options, and you can change your mind as labor progresses.
Exactly.
Okay, so the epidural's in, it's working. What about movement? Can you walk around, get out of bed?
Generally, no, not safely.
Yeah.
Because of the numbness or weakness you might feel in your legs, you usually need to stay in bed to prevent falls.
Right, safety first.
but you can still usually move your legs, you can shift your position in bed, roll from side to side, that kind of thing. You're not, like, completely paralyzed.
Okay, so not bedbound motionless, just need to stay in the bed. Got it. Let's shift to safety overall. They're safe, but there are always risks with any procedure. How are those broken down?
The really serious things like a blood clot near the spine, a bad infection, or lasting nerve damage are described as very rare.
How rare is very rare?
Less than 1%, according to the expert. So possible, but not likely.
Okay, that's reassuring. What about things that might happen a bit more often, even if less serious?
Well, one thing they watch closely for is a drop in blood pressure.
For the mother.
For the mother, yeah, which can then affect the baby's heart rate. But they monitor this constantly and can treat it quickly with IV fluids or medication.
So it was managed.
Yes, actively managed. Other possibilities include maybe some itchy skin or getting a headache.
And any other less common things to be aware of?
Sometimes the block might be patchy or only work well on one side. They might need to adjust the catheter or even redo it. Some women might have trouble emptying their bladder and need a temporary urinary catheter. A low-grade fever can happen too. And depending on the dose, you might feel that leg heaviness or some tingling.
Okay, a range of possibilities, but the serious stuff is rare. And things like blood pressure are watched carefully. You mentioned nerve damage as very rare, but it's often a big fear. What more does the expert say about that specific risk?
They reiterate, less than 1%. It could happen if the needle isn't placed perfectly or maybe bumps a nerve root. But the key thing they stress is that if it does happen, the symptoms like numbness or weakness are usually temporary.
Temporary meaning?
Typically resolving within a few weeks, according to the source.
Okay. And what about the other common worry, chronic back pain later on? Does the epidural cause that?
No. They state that back pain after having a baby is really common, but it comes from stretched ligaments, muscle strain from labor, and pushing. It's not caused by the epidural procedure.
That's a huge myth busted right there.
Seems like it, based on this expert's view and the evidence.
Let's circle back to those headaches you mentioned, spinal headaches. What are they exactly?
Right. Also rare, again, less than 1% risk. This happens if the epidural needle accidentally goes a tiny bit too far and makes a small puncture in the dura, the sac holding the spinal fluid. A little bit of fluid can leak out.
And that causes the headache. What does it feel like?
It's described as pretty distinct. A sharp pain, often front or back of the head near the neck. And the defining feature is it gets much worse when you sit or stand up and feels a lot better when you lie flat.
Oh, very positional.
Exactly. Usually starts within about 24 hours after the epidural.
And how are they treated? Do they just go away?
Often they do resolve on their own, maybe within a week or sometimes longer. Initial steps are things like rest, fluids, and pain meds. But the expert mentions a specific treatment they call the gold standard, which is an epidural blood patch.
Sounds interesting. How does that work?
They basically do a procedure similar to the epidural placement itself. They take a small amount of your own blood, usually from your arm, and inject it into the epidural space near where the leak happened.
Okay.
That blood forms a clot, like a patch, sealing the hole. And the relief from the headache is often immediate.
Wow, immediate relief. That's incredible. And you can get this even after leaving the hospital.
Yes, if the headache develops later, you can go back to have it done.
Good to know there's an effective fix if that rare complication happens. Thinking about the baby now, what's the impact of the epidural medication on them during labor?
Because the medication stays mostly localized, very little gets into the mom's bloodstream, so only a minimal amount reaches the baby.
Compared to other pain relief methods?
Right. Much less exposure than with IV opioids or general anesthesia, which can potentially make the baby sleepy or affect breathing at birth.
Are there any effects on the baby, even indirect ones?
Well, that potential drop in the mother's blood pressure is mentioned again. If the mom's pressure dips, it can sometimes cause temporary changes in the baby's heart rate pattern. But again, that's why they monitor both so closely and treat it quickly.
Monitoring seems key. The expert also mentioned epidurals have changed over time. What are the main ways they've evolved?
Probably the biggest change highlighted is using lower concentrations of the anesthetic medication now.
Why the change?
Apparently, in the past, they used stronger doses, and while it blocked pain, women often felt their legs were completely numb and heavy. They couldn't move them at all, and people didn't like that.
So patient feedback drove the change.
It sounds like it. The lower concentrations used today still provide good pain relief for the contractions, but often allow women to retain more muscle strength and sensation in their legs.
More movement within the bed, like you said.
Exactly. More comfort, more ability to participate actively.
Any other changes in how it's given?
Yes, the delivery method, they now use these specialized pumps connected to the catheter.
The ones with the button.
Right. The pump usually gives a continuous low dose, maybe an automatic extra bit, a bolus every hour or so. And then there's a button the woman can press herself, PCA, patient-controlled analgesia, to get an extra dose if she feels she needs it, up to a set limit.
So continuous background relief plus on-demand top-ups.
Precisely. It offers better, more consistent pain management and higher patient satisfaction, according to the expert, and less of that really heavy leg feeling.
It really sounds like the procedure has been refined quite a bit. Let's tackle another big question. Does getting an epidural make it more likely you'll end up needing a C-section?
No. An epidural does not increase the risk of cesarean delivery.
Okay, good to hear that myth addressed so clearly. What about needing help with delivery, like forceps or a vacuum? Does it increase that risk?
Here, the expert says it might slightly increase the risk of an instrumental delivery, but they add a really important clarification.
Which is?
Studies that show that link were often looking back at the older techniques that use those higher concentrations of medication we just talked about.
Ah, so the dose matters again.
Yes. The expert suggests that the lower concentrations used commonly today actually seem to promote normal, spontaneous vaginal delivery without needing instruments.
So that risk might be less of a concern with modern epidurals.
That seems to be the implication from this source, yes.
We've covered the procedure, the experience, the risks, the evolution. Are there any unexpected upsides or benefits?
Yes, actually a really significant one related to emergencies.
Okay.
If, during labor, something happens and an emergency C-section becomes necessary, having an epidural already in place can be a huge advantage.
How so?
Because they can often use that same catheter to quickly give a stronger dose of anesthetic enough for surgery. This means the mother can usually stay awake for the birth of her baby.
Instead of needing general anesthesia.
Exactly. The alternative, if there's no epidural, is often general anesthesia. That involves putting the mother completely to sleep with a breathing tube, and more of that anesthetic medication reaches the baby, potentially making them sleepier at delivery.
So the epidural allows for a quicker, potentially safer transition to C-section if needed, letting the mom be awake. Wow, I never really thought of it that way. That's a compelling point. Any other less obvious benefits?
They also touched on physiological benefits. Intense labor pain can really ramp up stress hormones, right? Which can raise blood pressure and heart rate.
Makes sense.
By effectively relieving that pain, the epidural helps lower those stress hormone levels, which in turn helps keep the mother's blood pressure and heart rate more stable.
So direct physical benefits beyond just feeling better.
Correct.
Okay, let's try and wrap this up for our listeners. We've gone through a lot of detail from this expert source. Why is digging into all this important for you as someone thinking about childbirth?
Well, knowledge is power, isn't it? Understanding the procedure, what to expect, the actual risks versus the myths, it just helps you make informed decisions.
Yeah, it lets you weigh the pros and cons for yourself based on facts, not just fear or anecdotes. And it puts those risks into perspective, knowing the scary ones are very rare and things like back pain likely aren't related, according to this expert.
Absolutely. And learning how much the procedure has evolved, often based on patient feedback, aiming for better comfort and more movement, that's reassuring too.
It shows medicine does listen and adapt.
It definitely can, yeah.
So as you mull over all this information we've unpacked from this expert source today,
Yeah.
maybe consider this. Thinking about how epidurals have changed over time, partly because women shared what they didn't like about the older methods. What does that suggest about the power and importance of sharing our own experiences within the healthcare system? Something to think about.